So welcome to today's webinar. This is part one of a four-part series of the AHA Cardiogenic Shock Research Series. It's called Idea and Proposal Process. My name is Melissa Clark, and I'm the Research Project Manager for the Cardiogenic Shock Registry. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Although there are no CEs available for this webinar, all attendees of the live event will receive a certificate of attendance along with the recording within about 2 hours after the conclusion of the event, and this will come via email. The presentation is also available as a handout, which you can download via the handout pane on your control panel. You'll also have the opportunity to submit questions by typing them into the questions pane of the control panel. You may send your questions in at any time during the presentation. We'll collect them and then address them during the Q&A session at the end of the presentation. If you experience any technical issues during the presentation, most can be resolved by refreshing your browser. If the issue continues following the refresh, please log off and try to enter again using the Chrome browser. You can also refer to the GoToWebinar customer service team, whose contact information can be found in your webinar confirmation email. To view live closed captioning for this webinar, please utilize the hyperlink that will be put into the chat. At this time, I'd like to welcome David Berg. Dr. Berg is an associate physician in cardiovascular medicine at Brigham and Women's Hospital. He's an assistant professor of medicine at Harvard Medical School and investigator in the TIMI study group. Dr. Berg graduated from Stanford University and has earned his medical degree from Harvard Medical School. Thank you so much for being with us today, Dr. Berg. You can take it away.
Thank you, Melissa. And I want to join Melissa in extending a warm welcome to all of you. We're thrilled that you're tuning in. And we hope that you find this first part, as well as the subsequent parts of this four-part series helpful. So as you just heard, my name is David Berg, and I'm a critical care cardiologist at Brigham and Women's Hospital in Boston. And one of the hats that I wear is serving as the co-chair of the Research and Publications Committee for the American Heart Association Cardiogenic Shock Registry. And so we thought that, and here are my disclosures before I hop in. And so we wanted to take a moment to talk a little bit about the registry. Many of you are directly involved in the AHA Cardiogenic Shock Registry or other Get With the Guidelines programs. And so wanted to take a moment to provide an overview of what AHA's Get With the Guidelines program is all about. So AHA, the Cardiogenic Shock Registry, is part of a core series of programs that fall under the broader Get With the Guidelines umbrella, which is really the backbone of the American Heart Association's quality improvement efforts and has been in place for essentially 2 decades now. There are a number of sort of core programs, and then there's a number of individual projects that have emanated out from that. And so if you take a look at sort of the impact and the reach of the Get With the Guidelines programs over the last couple of decades, it's been quite impressive. So there are more than 3,000 hospitals in the United States that participate in at least one Get With the Guidelines registry. And 80% of the US population is in a hospital service area that participates in at least one Get With the Guidelines registry. So a huge reach and really has been a huge boon to quality improvement efforts related to cardiovascular care in our country, and also an important tool for conducting research that then improves cardiovascular disease in this country. Focusing in on the Cardiogenic Shock Registry, which is really the focus of today's discussion, and one of the newest additions to the AHA Get With the Guidelines broader program. This is something that began just a couple years ago, and at this point in time, there are 120 active sites across 31 states, as well as the District of Columbia, that have been contracted and are participating in the Cardiogenic Shock Registry. So that number has continued to climb steadily over the last couple years. And with it, we've seen excellent patient engagement or site engagement in terms of entering data into the registry. So at this point in time, we have approaching 15,000 unique patient encounters of patients who had cardiogenic shock at one of the participating sites. And so we're really getting to large numbers of patients that allow us to do important clinical research. On average, there's about 700 new patients that are entered into the registry each month, and so that number is just going to continue to balloon over time. Really, really wonderful to see. A couple other sort of updates. So we're going to talk a lot about sort of the registry and research focus of the registry today, but the AHA Cardiogenic Shock Registry is part of a broader program. And so one of the exciting areas that we're excited about is that there are a number of projects that have kicked off in the last year. One has been the mechanical circulatory support use case. So that's a non-randomized prospective observational pilot study of registry collected safety outcomes using the AHA Cardiogenic Shock Registry platform. So more to come on that front. And so if you have any questions or are interested in hearing more about the Cardiogenic Shock Registry, I would encourage you to visit this website, heart.org/cardiogenic shock. The QR code is right here. And you'll find that this is a great tool, or there's a great interface for exploring a lot of the things that the registry is up to, looking at performance metrics, best practices, real-time reporting. So I highly encourage you after this webinar to go check us out. And then, as Melissa kicked us off with, this is, one of our latest efforts is to try to build a webinar series that allows clinicians with scientific interest to really engage with the AHA Cardiogenic Shock Registry and get the most out of the research process. And so we've had 2 cycles now of research proposals that have been submitted to the American Heart Association Cardiogenic Shock Registry. We'll talk about that process a little bit more later on, where the proposals get reviewed and they either get approved or sent back to sites. And what we've realized through that process is that we wanted to have a really, and particularly as more and more proposals are coming in and we're getting a lot of great ideas coming in, we wanted to take an opportunity to sort of help sites understand that process a little bit more and follow the sort of the life cycle of their ideas from conception all the way to manuscript generation. And so today's webinar is really focused on the ideas and proposal process, but I wanted to just put a quick word in for the upcoming sessions, the upcoming webinars. One is going to be led by my colleague, Dr. David Morrow, who is one of the chairs of the Cardiogenic Shock Registry. He's going to be talking about sort of the nuts and bolts of using the precision medicine platform as sort of the next step. Dr. Joanne Lindenfeld is going to be then taking through the process. Okay, now you have your idea, proposal, you've done the analysis. How do you put that together into an effective abstract that's likely to be accepted at a national scientific meeting? And then the final step is going to be Dr. Sunil Rao, who's going to take us through the process of okay, now you've had the abstract accepted. How do you take that idea and turn it into a manuscript that effectively communicates all of your ideas? All right. So now hopping into sort of the meat of the ideas and proposal, and I thought it was sort of important to start with sort of fundamental categories of research. And so the registry captures a lot of different cardiogenic shock encounters, and that's true of all of the Get With the Guidelines programs. And so fundamentally, the type of research that we're doing in Get With the Guidelines programs and in the AHA Cardiogenic Shock Registry is observational research. And there are unique things that can be done with observational research and unique things that can be done with interventional research. And so what do I mean by that? Well, interventional research is where something is being done to some subset of patients who are enrolled in that study. And it keeps kicking me out. Let me see if I can. And so the idea, so this, another way of saying this is these are randomized controlled trials. And the idea behind a randomized controlled trial is you're randomly assigning people to one of two treatment strategies or interventions. And the idea is to understand causal relationships, because you've eliminated all measured and unmeasured confounders between the exposure of interest and an outcome. So this is really the ideal study designed to assess causal relationships. But there are challenges to this type of study design. So one is that they're often done in highly controlled conditions that may not be reflective of the types of patients that are cared for in real world practice. And so there's always a question about external validity when it comes to interventional studies or generalizability. Do the findings of an interventional approach apply more broadly? There's obviously issues with that these studies being time consuming and resource intensive. And so although they're the cornerstone of determining causal relationships, there's some challenges with them. But one thing I want to impress upon you is that it's, in many cases, it may not be feasible to conduct a randomized controlled trial. And in many circumstances, the optimal study design for your scientific question is not necessarily an interventional one. And so what about observational research? Well, the caveat I'll put forward from the beginning is you cannot directly assess causality in a non-randomized study. And so that's an inherent limitation of observational studies. But there are a lot of advantages of observational studies. So one is we've collected all this data in the registry, and now we're ready to analyze. And so they're lower cost and complexity often. They're optimal for describing a population of interest. You really capture a real world population. We started by talking about the sort of the reach of the registry and how many patients are coming into this. And so you really get the sort of full gamut of types of patients with cardiogenic shock using the example of the shock registry. And then there's a couple other things that are important to be aware of with observational studies, which is that in many cases they're necessary when studying unassignable exposures. So for example, when you look at the relationship between smoking and lung cancer, you can't randomly assign a patient to smoke or not smoke and then follow them for cancer. That's not an ethical or feasible approach. And so an unassignable exposure needs to, and its relationship with outcomes needs to be explored through observational research. And oftentimes observational research is really foundational in terms of generating hypotheses. And so we'll come back to that idea a little bit more in a second. But I wanted to offer a couple examples of what I think are really good observational research questions, very good uses of observational data sets like the Get With the Guidelines registries and like the American Heart Association Cardiogenic Shock Registry. And there's sort of 6 broad categories that I would offer are good observational research questions. So one is descriptive epidemiology. We really rely on registries to understand the distribution of disease in populations, which is what epidemiology is about. And so describing the distribution of disease is critically important. Observational research often involves risk assessments or prognostic assessment. And in many cases, we're doing complex modeling approaches to understand what are the factors that are associated with higher risk of certain outcomes. Oftentimes in cardiovascular disease registries, we're talking about higher risk of death or other adverse cardiovascular outcomes. And so that's something that we can do with observational research. It's an ideal way to answer questions, or an ideal study design or study setting to answer questions about the natural history of disease and disease progression, about clinical practice patterns or utilization of particular therapies, about understanding quality of care or processes of care, which is really what the AHA Get With the Guidelines programs are all about. And then finally, sort of health disparities and equity questions are really best addressed in observational data sets. And so I wanted to walk through some examples of each of those as you're thinking about your ideas for submission to the Cardiogenic Shock Registry. So this was an example that is close to home, and this is a study that I did using another observational registry, the Critical Care Cardiology Trials Network. And so this was a study that we first did about 6 years ago and then kind of repeated with larger numbers more recently. But the question that we had is, if we took a population of patients with shock who are cared for in cardiac intensive care units, what is the types of shock that we see in cardiac ICUs? And among patients with cardiogenic shock, what are the main drivers of their cardiogenic shock? And that really the sort of paradigm for cardiogenic shock for many years has been that it's, acute myocardial infarction complicating cardiogenic shock. And so what we found is that about 2/3 of patients who are with shock, who are cared for in cardiac ICUs, have cardiogenic shock. And it was actually a minority of cases of cardiogenic shock due to acute myocardial infarction. And actually, the largest proportion of patients with cardiogenic shock were heart failure shock. And this and other analyses that came out around the time really led to a huge shift in our field towards thinking differently about AMI shock and heart failure shock. And it was really the work done through observational research that helped us understand the distribution of disease within cardiac ICUs. So that's an important sense of how, that's an important idea of how descriptive epidemiology can come out of observational research questions. The sort of second category of prognostic assessment or risk stratification has been a really ripe area within cardiogenic shock research over the last 5 years. And so one of the key themes in cardiogenic shock is that not all shock is created equal. It's a highly heterogeneous syndrome, varying etiologies, as you saw on the last slide, but also varying degrees of disease severity. And so a bunch of experts in our field came together about just over 5 years ago now and came up with the notion of the SKY shock staging system, which is a simple 5-tiered system for assigning levels of shock severity. And the notion when this group of clinicians and investigators came together was to try to come up with a common language that we all might use to communicate how sick or how severe a shock presentation was, and that might inform ultimately how we select specific hemodynamic therapies to support patients with cardiogenic shock. So many of you may be familiar with this system. It ranges from A, the at-risk patient, all the way up to E, which is the patient in extremis. But when this was first described, it was sort of a theoretical framework based on good clinical instincts. And so observational research came in to really ask the question is, does this model, does this conceptual framework actually validate when we apply this to a clinical population? And so really one of the first studies, if not the first study that sort of asked that question, was a study done out of the Mayo Clinic registry, in which the different SKY shock stages were operationalized within the variables available within that data set according to the framework that was laid out by those who developed the criteria. And indeed, there was the observation that there was a gradient of mortality that was reflected by SKY shock stages. So patients in lower SKY shock stages, SKY shock A, had lower risk of in-hospital mortality, and patients in SKY E had the highest risk of mortality, and there was a stepwise gradient. And so this was a good example of how of observational research or observational data sets allowed us to sort of validate risk stratification tools. Now, in addition, that's a fundamentally sort of a clinical risk modeling approach or clinical risk stratification, but there's a lot of questions that we ask using observational data that relate to risk assessment or prognostic assessment. And so another example is biomarkers. And biomarkers can be laboratory values, they can be hemodynamic parameters, there can be echocardiographic variables or other cardiovascular imaging variables, that can be histopathology. And these are all factors that are measurable and that relate to the disease in question and the outcomes in question. So I offer the example of a recent multi-center cohort of fulminant myocarditis, which often leads to, which is a cardiogenic a source of cardiogenic shock. And the authors in this cohort used this as an opportunity to describe the epidemiology of fulminant myocarditis, but they also did prognostic modeling work and identified 3 particular variables that were associated with adverse outcomes among patients with fulminant myocarditis. That was older age, lower presenting pH, and then giant cell myocarditis histopathology. So that was really a great data set for answering that question. Another question, another sort of area of observational research is natural history and disease progression. So this was work that came out of the Cardiogenic Shock Working Group Registry, another observational data set that describes how shock severity changes over the course of a hospital presentation. And so this was really instrumental in talking about how the SKY shock stages, which indicate disease severity, change over time, over 24, early on, and then over the course of 24, 48, 72 hours, and the prognostics associations of those changes over time. That fourth category I mentioned was clinical practice patterns and utilization. And so there's a recent example that comes from our very own American Heart Association Cardiogenic Shock Registry. This is work led by Sid Patel. And Patel and colleagues asked the question of, okay, so we have some data, albeit limited data, about what vasoactive agents that we might use to manage patients with cardiogenic shock, and sort of some weak guideline statements around that. But what are people doing in practice? What types of agents are people using? And so he looked at both vasopressors, or inopressors, as well as inodilators, and then pure vasopressors, and looked at just the proportion of total cardiogenic shock cases that were treated with each of these different type of agents. And this type of data, which can only really come out of observational data sets in terms of understanding how are people practicing in real world practice, are critical to informing how we think about what the population is doing, how we refine best practices, and then how we think about designing clinical trials. A fifth category is the quality of care and processes of care, which is, as I mentioned at the beginning, is sort of really at the heart of what the Get With the Guidelines is all about. And so this was an example from the Get With the Guidelines Heart Failure Registry. And what the investigators did in this analysis was look at guideline-directed medical therapy prescriptions at discharge among patients who are hospitalized with a diagnosis of HFrEF. And they showed that actually it's a small minority of patients that are discharged on the 4 pillars of effective contemporary guideline-directed medical therapies for heart failure. And these data are important to inform the public about what's going on in terms of quality of care that's being provided in our hospitals, and what are the opportunities to improve the quality of care. And these are the kind of data that often end up in guideline statements. And finally, an example of sort of health disparities or equity research that comes out of another Get With the Guidelines registry, the COVID-19 CV disease registry. This was an analysis that looked at patients with COVID-19 and cardiovascular disease and their in-hospital mortality rates, stratified by different race and ethnicity. And so with these data, we were able to sort of understand, or the investigators were able to understand, sort of the distribution of disease across important subgroups of interest that related to race and ethnicity, and that can inform sort of social programs and interventions. All right, so I talked about sort of 6 great examples of how to use or the types of questions that are perfectly suited for an observational data set. But I wanted to spend just a moment talking about comparative effective analyses, where we're looking at what are the outcomes of 2 different interventions. And I bring this up because I sort of view this as sort of Q-tips for removing earwax. We always say, don't do it, you shouldn't do it. But in reality, people use Q-tips to remove earwax. And so the key thing that this is an ENT doctor once told me is if people are going to do it, I at least want to tell them how to try to do it as responsibly as possible. And so the reason to go back to a theme that came up at the beginning is that we worry about comparative effectiveness is if I'm going to compare 2 different interventions, whether or not somebody gets treated with mechanical circulatory support versus not, with an inodilator versus not, with mechanical ventilation versus not, then there's clinicians are making decisions about which patients are best suited for each of those interventions. And those factors that go into a clinician's thinking about which therapies to select may often confound the association between that intervention and the outcome. So oftentimes it's sicker patients that are receiving more aggressive therapies. And so is it that the intervention is not effective, or is it just that sicker patients are receiving those therapies? And so that's the fundamental problem. That's called confounding by indication. And so what I'd offer is that if you're going to do comparative effectiveness research, you might want to focus specifically on cases where there's a question that's not likely to be addressed in a randomized controlled trial, either for feasibility reasons, or it's just not likely that it's ever going to be funded. And so those are the kinds of comparative effectiveness analysis that are best. If there's an ongoing active randomized controlled trial or one that just reported, that's probably not the best topic to tackle in an observational comparative effectiveness analysis. The other thing I would say is you have to think carefully about the research methods for causal inference. And so there's a number of different approaches, and I won't get into all of those details, but for example, propensity score methods or use of instrumental variables are important, and you have to be thoughtful about that. And so pairing with either epidemiologists or statisticians to think about the best approach to mitigate the risk of confounding in terms of understanding the relationship between exposure and outcome is critical. And then in the end, it's always important to acknowledge the limitations of non-randomized observational data and acknowledge that in the end, the associations you see between a strategy, a treatment strategy, and an outcome are ultimately going to be hypothesis generating and not definitive evidence of causal inference. All right. So those are some big picture ideas. The question then is, that you may be wondering, you say, great, I have been contributing to the registry now. I'm interested in cardiogenic shock. There's a lot of things that I've wondered about, how do I sort of start thinking about which questions to try to tackle? What are the best questions to go after? And where are the evidence gaps? And so I'd offer sort of three pieces of advice. One is draw on your clinical experience. There's nothing better than an enthusiastic clinician who thinks about the patients that are in front of them and says, hey, can we understand what's going on with this patient a bit better by leveraging the data that we get from large observational research registries. A second thing, sort of tip or pro tip I would offer is to consider new hypotheses based on recent randomized trial findings, and I'll come back to some examples of that in just a second. And then finally, and this is a key pro tip, is that you should consult professional society guidelines and statements, which often are a wealth of good ideas for coming up with new research questions. So when I say draw on your clinical experience, what I'm really saying is, what are the questions that come up on rounds all the time? For example, we think about hemodynamic parameters when we're managing cardiogenic shock patients all the time. What's the MAP target? What are the filling pressure targets? And so understanding sort of what are the prognostic relationships of these various hemodynamic parameters. That's a question that came up on rounds all the time, and that was a question I was personally interested in. But oftentimes those are the kinds of questions that might inform what you decide to go after in terms of your research question. What are the hemodynamic support strategies used in cardiogenic shock? There's a lot of questions that we can ask related to that. Mechanical ventilation practices, renal replacement therapy practices, understanding how are people practicing and how are others practicing related to the questions that come up on rounds all the time. That's sort of ripe area for then taking an idea forward for a research proposal. What about sort of new hypotheses based on randomized clinical trial findings? And I'm going to offer the example of the recent completed danger shock trial, which was really a landmark trial in our field of cardiogenic shock that randomized 360 patients with AMI-related cardiogenic shock to either standard of care, which really focused on volume, vasopressors, and inotropes, with a sort of consideration of escalation if patients were really doing worse, or standard care plus a microflow axial pump for at least 48 hours. And so I think it was a sort of really shook the world and shook the community when we saw that there was actually a profound and significant reduction in all-cause mortality in the group that was managed with microaxial flow pumps. So that was a randomized trial, an interventional study to address the question about the clinical efficacy of that therapy. But all kinds of questions can then come out of it. So do these data apply to the patients that I see in practice? And a colleague of mine, Connor O'Brien, used the C3TN registry data to answer exactly that question. He looked at nearly 5,000 patients with cardiogenic shock and then sort of ran all the inclusion and exclusion criteria, and ultimately arrived at only about a third of the patients with STEMI-related cardiogenic shock would actually qualify for the danger shock trial. And that actually only represents about 5% of all cardiogenic cardiogenic shock patients. And so it was a great question that came out of a recent randomized trial, and that could only be asked in a registry like the American Heart Association Cardiogenic Shock Registry, or one of the other cardiogenic shock registries out there. Another example of some of questions that might come out of the DanGer shock trial is, one of the key observations was that in addition to a clear efficacy and robust efficacy signal, there were also safety signals. And so patients who were managed with a microaxial flow pump had high risk of bleeding, of limb ischemia, of needing renal replacement therapy, of having strokes and infectious complications. And so you might then take those data and say, all right, what are the rates of each of these complications in real world practice? What are sites doing to sort of mitigate that, to try to understand the practice patterns associated with that? What are the risk factors for moderate or severe bleeding for each of these complications? So there's a whole host of questions that might come out of the randomized trial that can be best addressed using observational data sets like the Cardiogenic Shock Registry. And then to expand on the final point that I made about checking out guidelines and reviews, this is an example from a recent review that outlined research priorities in critical care cardiology. And oftentimes statements like this have tables that actually list specific topics in critical care cardiology research, or in research related to the topic of interest. And it's a perfect cheat sheet for saying, okay, a bunch of really smart people or experts are saying these are the questions that we should be addressing. And then you can say, hey, that's a question I should be addressing. So you bring in your clinical insights, you might bring in ideas from randomized trials, but then consult these lists, which give you important ideas that are worth pursuing. And here's an example of an American Heart Association scientific statement that's almost a decade old at this point, looking at contemporary management of cardiogenic shock. But at the end of that, at table 8, there was a list of potential priorities for future cardiogenic shock research. And it was sort of humbling as I pulled up this list to realize that we still don't have answers to a lot of these questions. And so this was a table that sort of listed a number of the key research questions that we need to address. And they even had a column of what's the ideal study design. And so if you could even look at that list and say, what, registry-based research, and get ideas from the list that, again, a group of experts put together as being valuable for research questions. All right, so you have an idea. This is a book that I read to my kids all the time. And so then now what? What do we do? And so although this isn't the answer that's given in this children's book, I would say that the next step in the process is to get to know your database. And so what do I mean by that? I mean that you really have to know the case record form inside out. For those of you who are entering data into the registry, you may already have a good sense of the case record form. But it's critical to understand which variables are collected. It's also critical to understand which variables are not collected. And the reason is that you want to make sure that the questions that you're asking are realistic. It may be there's a deal breaker. You're totally interested in understanding what are the sedation practices for patients who have cardiogenic shock. Well, if you look at the case record form, we don't have any details about sedation at this point in the registry. We have a ton of other information there, but we don't have that information captured in the registry. And so that's not the right question to ask of this data set. It may be available in other data sets, but that's not in this data set. But there's a ton of information that's collected. And so you really want to think what's unique about your database. So it may be that there's as you're kind of pouring through the case record form, you realize, hey, this is information that's uniquely captured here that wouldn't be available in other shock registries, for example. And that's why this is a particularly good question to leverage this research tool. So I encourage you can't know your case record form too well. Have that by your side as you're putting together a research proposal. All right, so now you have your idea, you've thought about what are good questions, and now you have to put a pen to paper and think about your study design. And I wanted to offer a few sort of words of wisdom around that. One is to be thoughtful about the inclusion and exclusion criteria. You want to make sure that you're homing in on the population of interest, but you want to also make sure that you're not being too restrictive and ending up with a sample size that's too small to sort of be able to realistically answer that question. And it's not to say that there's no value to some questions where you really want to hone in on a small population, but the registry might not sort of be ready enough. There may not be enough of those types of patients in the registry yet to answer that question. And so that's one that you maybe table for the next round of proposal review. But right now you go after a question that can be answered. I can't say this enough, but don't underestimate the importance of a clear denominator. As you're framing your questions, you really want to understand what's the population of interest. There's so many times that particularly as you're diving into your analysis, you realize, oh wait, this is not actually the group that I meant to say, and I'm looking at the proportion who are receiving X therapy, but actually I sort of wasn't thinking about the group that is not included here based on the inclusion and exclusion criteria I was applying. You'll want to think carefully about your exposure of interest. So what's your primary comparison? And then do you want to stratify the analyses? And so I'll offer a recent example. So one of the early questions that was asked to the registry is, what was the association of initial presenting sky stage with risk of in-hospital mortality? In this case, the primary comparison of the exposure of interest was sky stage. The outcome was mortality. But there was a stratification, which was a pre-specification of subgroups of interest. Meaning that we wanted to look and understand the relationship between sky stage and outcomes and whether that varied based on whether a patient had AMI shock or heart failure shock. And that's what's meant by stratification. And as you think about outcomes, you of course want to focus in on things that are meaningful. Mortality is often what we talk about in cardiogenic shock because it's such a morbid and mortal condition. But you also want to talk about things that are measurable or that are, and specifically that are obtained within the case record form. And that's where coming up with or being familiar with your case record form is so critically important. A couple additional considerations that I'll offer. One is that as you're putting together your proposal, you want to think about your team. So think about potential collaborators at your site or others. One of our jobs as a research and publications is to often pair you with other collaborators if two people submit very similar proposals. And so part of that is our job, but you may think about sort of pulling in multiple collaborators right up front. You'll also want to think about your statistical support. So most of the proposals we're talking about are going to be through the precision medicine platform, and that requires your ability to actually do statistics on that platform. And so you want to make sure a strong proposal has a clear vision for who's going to be doing the statistical analyses. As you submit a proposal, you should, it's incredibly helpful to actually generate table shells. And the reason that's so valuable is it forces you to answer the question of how do you want the data to appear once you're all done with these analyses? How is that you're going to present those data to a reader? And the more detail you can provide, the better. And the reason that's important is that often exposes that you've thought about, hey, I want to understand the relationship between sky stage and outcomes, but one of the key things is I want to understand what are all the other clinical characteristics of patients in Sky B versus Sky D. What are the different resources that are used? And so by putting pen to paper in table shells, you often realize sort of what are the key pieces that or key variables that you need to highlight in your proposal. It also helps us as a research and publication committee really understand what you mean by what you say you plan to do. A key thing I want to emphasize is that you may be uncertain about this process. Perhaps this is the first time you've engaged in major clinical research. Perhaps it's the second time, third time, but you haven't done the type of analysis that you're proposing. And what I want to encourage you is that there's a bunch of us on the back end. It's not just sort of a computer interface that you're submitting proposals. Ask for help. We're here and we want to support you in developing a good proposal. And so, but well ahead of the submission deadline, I would encourage you to reach out to us to help you build a good proposal. And then, just to sort of be aware of that, we, as I mentioned, as a research and publications committee, will consider overlap between proposals, but you may want to sort of check out the list of prior publications that have come out of the registry and proposals that are already active. And you can see in the handout, there's a link to that, which will sort of help you understand. You have a great idea, but if it was just done and just published, it's going to sort of diminish the priority of that question in this particular registry. All right, so let's talk about the proposal submission process. and sort of try to clarify any questions and sort of unmask sort of any mysteries. So the most proposals submissions, as I mentioned, are for self-analysis, where you are going to be doing the statistical analysis yourself, and that's done via the Precision Medicine platform. We're going to be diving into that in the second part of the webinar. Some analyses are conducted by an AHA analytic vendor or by the AHA data science team, and those are sort of a select few. And if you're going to submit a proposal, you have to submit a your research proposal through a specific template, and it has to be uploaded to the proposal central. And so it's not okay. We've had some issues in the past where people have submitted a Word document, but it never made it into Proposal Central, and unfortunately, then it led to delays in those proposals ultimately being reviewed. And so make sure that you use the Proposal Central for submitting the proposals. A sort of small point, but international researchers require an IDDQ in order to submit their proposals. All right, so the Research and Publications Committee reviews proposals to determine feasibility and to prioritize based on the scientific quality and the priority of the question. So as we're thinking about the review process, we're thinking, have you thought about how this is going to be done? Have you thought about sort of the feasibility of the question? And did you have high quality tables that were in there, a clear plan for statistical support? But also, is this a good question? Do we think that this matters to the field? All of those are going to be kind of sort of coming into how the proposals are scored. And so as we think about the transit of proposals through the process, first proposals are received. Then there's an initial review and feasibility assessment, an assessment of individuality. Then two RMP committee members grade the proposal, and that comes up with an average score, which then allows the proposals to be ranked, and then that ranking is brought forward to the full Research and Publications Committee for a final decision. And so those initial grades sort of help tier the priority, but then there's a final vote on all the proposals based on the sort of feedback of the dedicated reviewers. And once that happens, there's sort of one of three potential outcomes of our proposal. It's either going to be approved, you could receive a decision of revise and resubmit, or it's a reject. Those are sort of the three possibilities. And if it's approved, the next step in the process is to return that decision, but also to assign a mentor from the Research and Publications Committee who can help shepherd you through the process and make sure that you're kind of hitting milestones thereafter. More to come on that in the next installment of the webinar series. And if it's a revise and resubmit, you'll get the comments back from the Research and Publications Committee so that you can improve your proposal and hopefully submit it the next time around. One thing to note, and we'll be talking about this more in the third and fourth installments of the webinar, but just to sort of set expectations early, all scientific output that comes out of the AHA Cardiogenic Shock Registry, whether that be abstracts, papers, public reporting of data, requires review by the American Heart Association before submission to the presentation and publication. It's really a 2-week timeline ahead of deadlines for submission. And so what about timing for proposals? Some of you may be aware of this already, but just to remind you, and we'll continue to remind you, that for the Cardiogenic Shock Registry, we'll be accepting proposals. The RFP is about to go out, and we'll be accepting proposals through November 30th, at which point there'll be a hard deadline, and we'll review those proposals for the next cycle. Starting in 2026, we're going to move to the more traditional timelines, which is going to be February 15th and August 15th. So there'll be reminders about that coming out, but the next submission cycle is still November 30th, which is what we've adopted in these first couple of years. So the good news is there's actually 3 bites at the apple within the next 12 months, the November, February, and August deadlines. For the other Get With the Guidelines submissions, for the AHA funded proposals, for the AFib, coronary disease, CAD, heart failure, and stroke Get With the Guidelines registries, those deadlines are February 15th and August 15th. For resuscitation is a little bit different. Proposals are due by the 30th of every odd month. And then another deadline to be aware of is the early career investigator submission cycle, which is October 16th. I'll come back to that in just a second. For the other registries, not cardiogenic shock, we accept proposals for self-analysis through the precision medicine platform on an ongoing basis throughout the year. But for cardiogenic shock, the PMP proposals, it's really that November 30th deadline. I mentioned briefly about the early career investigator awards, and so that deadline is October 16th. I would encourage you to check out the sort of requirements for that and think about whether you might be eligible to get one of those awards. It's a really great resource to help you to conduct the research. And with that, I will pause and happy to take any questions.
I'll remind everyone that you can still submit your questions through the questions pane in your control panel. I do have some that have come in via email while we've been on the call. So Dr. Berg, can you describe how mentorship is integrated into AHA's support structure for new investigators? Is it primarily peer-to-peer, formal assignment, or self-initiated?
Yeah, it's a great question, and I'd say one of the core values of the registry is mentorship, and not only answering scientific questions, but giving you the tools to be effective in answering those questions. And so, like everything, there's a process to learn how to do that effectively. When you submit a proposal, there should be a primary author, and there also is a dedicated mentor on that project. So as you're thinking of submitting proposal, you should be thinking about who's going to be usually it's somebody at the same site as you. It doesn't have to be, but often is, but a mentor who that you're choosing to be overseeing a particular clinical research project. But then at the registry level, from an RMP committee level, once you have a proposal that's been accepted, we assign a research and an RMP committee member to be another member that's overseeing the process and help you think about some of the challenges that come up with clinical research and how to think through all of the details of how to design that effectively. So that's something that we provide you on the back end, and that's somebody who's going to be checking in and ensuring that there's progress being made. And then the final step I'd say is that you get this sort of mentorship of the broader committee when you ultimately submit a potential scientific output. As I said, you have to do that, which is sort of a thing to pay attention to, but the value of that is you also get input from the whole AHA team, and oftentimes you learn from the feedback you get from that.
Excellent. Next question. Could you explain the limitations of current AHA data, variable completeness, linkage to external data sets, long-term outcomes, and how investigators should anticipate and design around those challenges?
Yeah, so that's an incredibly important question. Missingness is, for those of you done clinical research, you realize that is the sort of question number one. So, and that should be top of mind for any question. So, the first thing to be aware of is obviously know the case record form. That doesn't tell you about missingness, but it tells you what is potentially out there. And then if you one of the things that happens before the proposals are reviewed is there's a feasibility assessment. And so part of that is looking at the key variables that are specified in the proposal. And then there's an assessment of missingness. You can definitely, we actually encourage you to reach out as you're putting together a proposal to ascertain questions of missingness that may be very relevant to your proposal before you sort of take a deep dive into that. So again, we encourage you to reach out. Right now in the registry, I mentioned that we're close to about 15,000 unique entries or unique patient encounters for cardiogenic shock. We have some criteria of sort of core clinical variables that are being collected and that sort of designate something as complete, where they have, clinical information, outcomes, sort of all what we think is sort of our key variables. And probably about half of the 15,000 actually are complete at this stage. They might only be missing sort of some components, and so there might be sort of near complete information. So that doesn't mean that only half of those are actually analyzable. It depends a little bit on the specific question, but just to give you a sense that it's very much a registry in progress. It's a live registry, and so the completeness keeps getting better and better, but it's a valid question. One of the areas we've been particularly focused on is the serial shock assessments. We have relatively limited data right now in the early days on sort of what happens with hemodynamic parameters over time, for example. It doesn't mean that there's nothing there, and we're definitely increasing how much we have available, but that's a good example of where there's still quite a bit of missingness in the registry.
Thank you. Is there a limit to the number of proposals that get approved?
I would say the answer is no. There are some so the value of the self-analysis and the precision medicine platform is that we're not sort of restricted by statistical bandwidth, which is often a limitation for how much can be done. So if you have a good proposal, we want to support it. And so it's really dictated by the quality and of the proposal that's submitted. There may be some considerations. I think what naturally happens is that the more as we get more and more proposals, the quality keeps getting better and better, and so it inherently the bell curve or the distribution of quality proposals means that you're kind of being benchmarked against other people. But I would say that what we want to do is fund is good questions and good projects. And so don't be discouraged by that. And the other thing I would say is that you shouldn't be, it's okay to submit multiple proposals from the same site. A number of shots on goal, as a mentor once told me, is a good thing. If you only take one shot on goal and it doesn't hit, then you're sort of out of luck. But multiple proposals is certainly encouraged.
Terrific. One last question. How does AHA prioritize investigator access to data sets when multiple requests for similar analyses are received? Is there a process to ensure complementary work rather than duplication?
And so if I just want to make sure I understand the question correctly, is that if there was it that if multiple people are interested in the same question or in complementary questions? Do you mind just saying that one more time, just so I?
Sure. It just says, how does the AHA prioritize investigator access to data sets when multiple requests for similar analyses are received?
Yeah. Okay. Good. Yes. So what I'd say is that oftentimes that is a case where there are very similar types of proposals that are received. And so oftentimes, if we see that and we think that they're both good proposals, we will encourage those investigators to collaborate. If there's one that is a particularly strong proposal and one that's a weaker proposal, we might suggest that that those who submitted the weaker proposal join the team that's a stronger proposal, but the team that submitted the stronger proposal might be the leading team. And so we are looking for those connections, and we really certainly want this to be a collaborative research experience. And so you may get feedback if you submit a proposal that says, great, we want to accept this, but we want you to work with another team. I realized I didn't completely respond to one of the previous questions about missingness and sort of available data with respect to outcomes. And so all of the registry focuses on in-hospital outcomes at this stage, although there's work ongoing to try to link the AHA data set with other data sets that will allow for assessment of longer term outcomes, hopefully one day. But right now it's all focused on in-hospital outcomes.
All right, fantastic. I want to thank everyone for attending. I'd like to thank you, Dr. Berg. Once the webinar is over, you'll receive an email with a short survey, and we'd appreciate it if you'd be able to complete that for us and give us your feedback. I'll remind you that you'll receive the follow-up email within 2 hours with a link to view the recording today, along with your participation certificate. So thank you so much for joining us today. Thank you for your commitment to the AHA, and enjoy the rest of your day.